Now it's my pleasure to introduce Akiko Shimamura. She is director of the Bone Marrow Failure and Myelodysplastic Syndrome program at Dana-Farber and Boston Children's Cancer and Blood Disorder Center, and also professor of pediatrics of Harvard Medical School. Title of her talk is Pediatric MDS. Please, Akiko.
Thank you so much for the kind invitation to participate in this session, and I hope that I can convince, since most of you are probably adult MDS doctors, please don't leave for coffee now. I hope to convince you that this is relevant to your practice as well. I have a consulting agreement with Novartis, but it is unpaid. I've declined payment, and I also run a clinical trial that is funded by Novartis. Whoops. So as we think about pediatric MDS, it has some, generally speaking, have some clinical distinctions between those that are typically associated with MDS arising in older adults. For example, in pediatric MDS, the marrow is typically hypocellular. It's typically empty, as opposed to the hypercellular marrows typically found in older adults. In terms of cytogenetics, as mentioned by the previous two speakers, monosomy 7 and deletion of 7q are common, very common, in pediatric MDS, whereas 5q- and ring sideroblasts are exceedingly rare in pediatric MDS. The somatic mutation profiles have been described most recently by Jeff Klopp group in St. Jude, and they found that RNA splicing mutations are exceedingly rare in pediatrics compared with adults, and that somatic RAS-MAP kinase mutations are quite common, particularly in advanced MDS. Now, as mentioned by the previous speaker, pediatric MDS often evolves from bone marrow failure, and there are a lot of disorders that have been associated with bone marrow failure. However, it is exceedingly important to recognize that the initial presentation of a bone marrow failure syndrome can be MDS. Right, so that can be the first thing that brings them to clinical attention. So the absence of a prior antecedent bone marrow failure presentation does not rule out these disorders. Secondly, germline genetic predisposition is quite common, and the frequency varies with the denominator that you choose for your cohort. And I think Dr. Čerpek described this very nicely in her talk. Some clues and some cytogenetic abnormalities that are typically associated with a higher frequency in some of these germline genetic MDS disorders. Monosomy 7 and del7q, as mentioned, are found in pretty much all the inherited bone marrow failure and MDS predisposition disorders. Gain of 1q or gain of 3q has been described as a frequent chromosomal cytogenetic abnormality in Fanconi anemia. Del20q and isochromosome 7q have been shown in Shwachman-Diamond syndrome. Indeed, these are the most common cytogenetic abnormalities we see in the Shwachman registry. However, interestingly, and this has been studied in a lot of detail by our colleagues in Italy with Pasquini and Emanuela Maserati and others, that the del7q in particular does not appear to confer an increased risk of progression to MDS. And then trisomy 8 is common in GATA2, shown by the EWOG group and others with Marcin Lodarski. So the diagnosis of pediatric MDS poses some unique challenges, and indeed it's been difficult to sort of cubbyhole pediatric MDS into the criteria proposed by the WHO criteria, which frankly are based on adult MDS, right? Now, in recognition of this, the WHO classification that was revised recently does include a new category called refractory cytopenia of childhood, or RCC. And this is a morphologic category that can be readily distinguished. The challenge has been to know how to utilize this category clinically to guide diagnosis and management. And there have been sort of different types of studies with different conclusions as to the clinical significance and the implications of RCC. So this requires further study. Furthermore, the distinction between low-grade MDS, which is often hypocellular, compared to bone marrow failure, can be quite challenging in these disorders. Conversely, the distinction between advanced MDS versus AML can also be challenging, and I'll give you an example here. There was a patient who presented to our center, a 10-year-old with Shwachman-Diamond syndrome. You're going to hear a lot about Shwachman-Diamond syndrome because that's a particular interest of mine, but I think it illustrates several general concepts that are broadly applicable. So he had been noted by his primary hematologist that his blood counts had become lower than his baseline. So his baseline counts were low, but not this low. His ANC was now 500, hemoglobin 8.5, platelets 30,000. And so he did a bone marrow appropriately, and his bone marrow showed 20% cellularity, which was a little bit lower than where he typically ran, but he had complex cytogenetics, which was new for him, and he had 24% blasts. So this was, based on the blast count, there was concern for AML, and he was emergently sort of referred up to Boston. And 1 month later, he had a follow-up CBC prior to hopefully initiating treatment, and his CBC actually throughout all this had remained stable. It was exactly the same, really, and actually it was a little bit better. And there was no evidence of tumor lysis. The marrow cellularity was stable, and the blast count was stable. If anything, it was a little bit lower. But it was still high, right? So what is the significance of a greater than 20% blast count in a hypocellular marrow, right? The absolute blast number is markedly lower than a greater than 20% blast count in a packed marrow, a 90% cellularity marrow. So is it the absolute blast count that we should be worried about? Does this carry the same implications? And the biology of this, the clinical biology, feels different from AML. There's no progression. It's just kind of smoldering there. It feels more like an MDS clinically. And this has been discussed very elegantly by colleagues from EWOG, particularly from the group of Charlotte Niemeyer and Franco Locatelli. They've written some really nice articles on this and perspectives, which I encourage you to take a look at. So as mentioned by all of the other speakers in this session, there are sort of syndromic features that can be associated with many of these disorders that can give you a clue to the underlying genetic cause. But the question is this distinction, because I hear this a lot, both in the literature as well as in discussions at meetings of these are syndromic disorders, these are non-syndromic disorders. And this is sort of an artificial distinction. I mean, virtually all of the syndromic disorders can present with any apparent clinical stigmata, or they can have the wrong clinical stigmata. They can look like a different bone marrow failure disorder or genetic MDS disorder and get misclassified. And this has really come to the forefront with the advent of genetic testing. And most groups, there are multiple groups here, including the groups, our group, groups from Japan with Seiji Ogawa and Seiji Kojima, as well as Jean Soulier's group, Yigal Gror's group in Toronto, and many, many others. I'm sorry, I can't list everybody. And we're finding that about up to 20% of patients are misdiagnosed. We think that they have an inherited, MDS bone marrow failure disorder, but we get the wrong one because the patient forgot to read the textbook, right? They're showing up like somebody else. And these carry completely different clinical implications. The comorbidities are different. The way that we survey them and monitor them may be completely different. Furthermore, patients with what have been described as non-syndromic disorders can present with other medical issues that can mimic a syndromic disorder. So I don't personally use this syndromic, non-syndromic distinction. I find it to be artificial. So I personally avoid it and just refer to them as genetic disorders. MDS and AML are often, unfortunately, lumped together in the published literature. We must try to avoid doing this because really they're distinct. Furthermore, the definition of MDS was unclear in many of these papers. There's no consensus on how to diagnose MDS in these genetic predisposition syndromes. The definition of MDS has evolved over time. So something that we would have called MDS, 10 years ago may not be relevant to what we're calling MDS now. So we undertook a collaborative study to investigate the clinical features and outcomes of MDS and AML and Shwachman-Diamond syndrome. And this is work that has been submitted, and I don't have time to take you through all of it. I just want to give a shout out. You cannot study rare diseases without collaboration. And this was really a wonderful coming together of many investigators throughout North America. This is something that's been alluded to by the previous two speakers. I get asked this all the time, what is the cutoff age for young adult MDS, right? We've shown you that there's some clinical distinction between young MDS versus older MDS. When do we need to stop worrying about young MDS? So getting back then to the issue of somatic mutations in genetic MDS predisposition, this has been discussed already in previous talks, but I just wanted to bring your attention to this really intriguing observation that the germline genetic mutation seems to inform the somatic mutations that subsequently develop. So although both severe congenital neutropenia with Elaine mutations as well as Shwachman-Diamond syndrome are associated with neutropenia, right, it's the most common cytogenetic abnormality in Shwachman-Diamond syndrome, the somatic mutations in SCN are typically in the CSF3R gene, and in Shwachman-Diamond syndrome we see P53 mutations. With GATA2 you can see a range of different types of mutations. In Fanconi anemia, in work from Jean Soulier's group, RUNX1 is the most common mutation. And I've listed some of the publications here. Ivo Tau has really done groundbreaking work in SCN together with Carl Welty's group and others. And Coleman, as I mentioned to you before, Coleman Lindsley and Dan Link, and we collaborated with Dan, looked at TP53 and Shwachman-Diamond syndrome. I'd like to point out, though, that it's kind of curious. This would not have been predicted from preclinical studies. For example, if you knock out P53 in a Fanconi anemia zebrafish model, which shows the developmental abnormalities and the cytopenias. This was modeled by Tom, I'm sorry, I'm totally blanking on his name. Tom, you know, that famous doctor who works on malignancies at Dana-Farber, he showed that if you knock out P53, you can rescue the developmental abnormalities as well as the cytopenias in Fanconi anemia, right? So you can overcome this abnormality with P53 mutations, yet Fanconi anemia, you don't see P53 mutations popping up so readily. You see it in Shwachman-Diamond syndrome. And P53 mutations can also correct DBA abnormalities, et cetera, et cetera. And Jean Soulier has also modeled in Fanconi anemia P53 mutations. So there's something distinct about the biology of the germline mutations that really drives and informs the somatic mutations. With respect to the question, how do we use the somatic mutations to inform clinical management, it's important to recognize that most of these studies so far have been mostly cross-sectional studies at a single time point, right? So you get a snapshot of what mutations are in a patient at a given time point. There's very little in the way of, there's a little bit, but not a lot in the way of longitudinal analysis. And we really need longitudinal somatic genomic analyses with clinical outcomes in order to better inform what to do with these mutations. So I think that we'll see this has been, there were excellent talks throughout this symposium talking about the negative selection pressures on hematopoiesis exerted by aging, by chemotherapy, and now by genetic predisposition, affecting a variety of different molecular pathways that then, through this negative selection pressure, exert sort of a pressure to develop somatic mutations to drive clonal escape, clonal outgrowth, and then progression to MDS and AML. And if we can understand the biology underlying this, as opposed to, in addition to describing the mutations, but also trying to understand the biological implications, that may be able to inform both our clinical management as well as our development of therapeutics. And I just wanted to mention that in terms of therapeutics, we in pediatrics, as well as we in bone marrow failure, have been really challenged by the absence of a clinical trials network. I've been long jealous of all of the oncologists because you all have these wonderful clinical networks. So once you discover something in the lab, you can sort of shuttle your findings into a clinical translational study. So to address this challenge, I worked with David Williams at Boston Children's Hospital. I was at Seattle at the time to organize a pediatric consortium, and now there's over 40 centers across the United States. Some members are here. Seth Quarry is here. He's a member of NAPAC. And originally we focused on bone marrow failure, but we have now branched out into MDS. We have a few clinical trials ongoing, and we hope to get some biological studies going as well. So in conclusion, the diagnosis of pediatric MDS remains challenging. And I think that we're moving now towards more biology-based, age-unrestricted approaches to MDS. We shouldn't cubbyhole ourselves as saying we don't need to worry about these disorders below a certain age. I think they can present at a variety of ages, and we really should try to, as our ALL colleagues are doing, try to focus more on the biology as opposed to these artificial restrictions of age. And germline genetics exert distinct selective pressures that drive different mechanisms of clonal evolution. And I think that the understanding of biology, of course, may inform, hopefully, therapeutic strategies. So I just wanted to thank everybody with whom I work in the bone marrow failure program in Boston, and I'd like to just stop here. Thank you.
Thank you, Akiko. So there is time for one question, please.
Thank you very much for this beautiful presentation. You show a slide of Schwachman diamond follow-up patient in which you show a different outcome in those who are surveillance. Could you please describe exactly what do you mean, how frequent did you did the bone marrow evaluation?
Yes, so that's an excellent point. It is all over the place. So some people had regular yearly surveillance marrows. Some people had sporadic surveillance marrows. We defined surveillance marrow as a bone marrow exam that was performed in the absence of a suspicion of MDS or AML. But I've noticed through the Schwachman registry 2 flavors of progression to MDS and AML. Most of them smolder along, which is why we do surveillance, right? So you stand a chance of catching them before they develop AML. Right, so they sort of go through this phase where they get more sort of MDS-y. But there are some patients who, there's a handful of patients who unfortunately, out of the blue, a few months after their surveillance marrow, which looked baseline, developed AML. And I actually had our central pathologist review those marrows. I'm like, oh, maybe those centers just aren't very experienced. We really need to have an experienced hematopathologist look at them. They cannot see anything abnormal in those marrows. There is nothing in cytogenetics. So now what we're doing is doing deep sequencing through the Broad with Coleman-Lindsley to try to understand the clonal genomic sort of landscape across time to see if we need better metrics to try to identify high-risk patients to risk stratify. And I think the converse of that is, it's also, I would love to be able to spare those children at low risk of progression from these yearly marrows. I mean, it's terrible to have a yearly bone marrow.
But do you think that the era of NGS, we can eventually think to do something from peripheral blood?
We're investigating that as well. So that has, of course, in adult MDS, they're using peripheral blood, but it's a little bit different in pediatric because it's hypocellular, so we just want to make sure that it's as sensitive. But we actually have paired marrow and blood samples, so we plan to look at that as well.